Thanks so much for having me here. Jake Hutchins, this is year number 6, so I missed last year, but appreciate being welcome back here to give a lecture on aortic dissections today with you. These are my disclosures. So I tried to set this up as a case presentation because we've had a couple of aortic dissections come through in the last month or so. At our institution, we're not a big aorta institution. We've had a couple come through our ER, which then found their way up to the OR with us. So we had a 67-year-old female presented to the outside hospital with a history of hypertension. She had intense back pain and hypotension and waxing and waning mentation. So this brings us back to kind of our medical school training on what's our differential diagnosis. And hopefully your emergency rooms are going to be thinking about this kind of right off the bat. And really what this is aortic dissection is some sort of an intimal tear where the blood exits the true lumen and then dissects the aortic wall, creating this false lumen. You can see in the top circle up there, you can see the intimal tear that has occurred, and then the blood going from the aorta into the false lumen, and that creates that dissection. And that dissection can be either proximally or distally from that tear. So it doesn't have to just occur where the tear occurs and then go distally. It will go both ways. And again, you can see here how the blood leaving the true lumen really can dissect both proximally and distally from that site. So what are the risk factors? Well, the major ones that we see are hypertension, and this is because of the hyaline arteriosclerosis of the vasa vasorum. This decreased flow in these hypertensive patients then leads to atrophy of the media, and this is what this patient had as a history of hypertension. The other ones that you should have a high differential diagnosis of these patients are those with inherited defects, so typically Marfan's, Ehlers-Danlos, and these are going to be younger patients than those that have hypertension. And it's there we go. We can do the cystic medial defects. We have our typical classifications here, and you've been taught these for several years now, going through the various forms. There's a DeBakey classification going through 1, 2, 3A, and 3B, as well as a Stanford, which is type A and type B, and type A being anything involving the ascending aorta, and type B being limited to the descending aorta. There's been several other types of classifications that have come out over the years since these have been developed. Those trying to really have a better functional definition, but I think why these have stuck is because they're so easy to remember, and sometimes we get too complicated with their classifications and nobody ever really adopts them. I think ease of remembering and ease of adoption tends to be key with some of these systems, as we've seen in how we evaluate the aortic valve or the mitral valve. The more complicated methods tend to be ones that aren't used as often. So again, type A, these are going to involve the ascending aorta, and this is typically a surgical emergency. Mortality rate in these patients is about 1% per hour for the first 48 hours. So when this is found, you want to get these patients into the operating room as soon as possible. After 48 hours, it's 60% mortality by 1 week, and 74% by 2 weeks, and 91% by 6 months. So once these type A dissections are found, you want to get these patients in the operating room and operate on them as soon as possible. Why is there a high mortality rate? Well, there's a high risk of rupture. Tamponade can occur. Myocardial infarction, this is because sometimes this does involve the coronary arteries. Severe acute aortic regurgitation, as we saw from some of the previous talks here today talking about aortic dissection. Stroke from brachiocephalic dissection, as well as malperfusion of the bowel, limb, or renal ischemia. Type B is limited to the descending aorta. It's usually medically managed unless life-threatening complications are occurring. And this is because medical management mortality typically has been shown to be less than surgical mortality. So these patients typically do better just with medical management unless there's some of these other complications that are occurring. If they do operate, very commonly this is done by a TEVAR. And you heard previously about some of the uses of TE and the TEVAR procedures as well. So diagnosis, I know there's some discussion about this in the aorta talk. TE may be preferred over the other modalities, and this is because it has high sensitivity and specificity. It's portable, doesn't require radiation or contrast. It's quick, done 15 to 20 minutes. You have a definitive answer once the test is done. But some of the other issues with it is most time these patients present to the emergency room. And at our institution, CT angio is going to be the way to go because it's something that can be done relatively quickly from the emergency room. We typically don't have someone standing by that can go and perform TE very quickly in the emergency room when these patients come through the door. And so just because of the ease of use of, and sometimes just the technical aspect of who's going to be able to perform this, isn't someone that's there 24 hours a day, 7 days a week at our institution. And so a CTA is usually going to be the way to go with this. So this patient did have a CT and CTA at the outside hospital, showed a type A dissection from the aortic root down to the iliac bifurcation. This patient was transferred to our hospital. It was about an hour and a half away. But they were helicoptered in, brought to the emergency room. Patient was induced, lined, and a TE probe was placed. Think about what types of things we're going to look for with our echo probe. We're going to try to identify the intimal flap. Really look at the extent of the aortic dissection, where it starts and how far down it goes. Does it go all the way down, above the diaphragm, below the diaphragm? Identify the true lumen, identify the false lumen. We talked about that in the earlier lectures. Are there any thromboses in the false lumen? Localize the entry and exit of the tear where you can find it. Assessment of aortic regurgitation. Assessment of the coronary arteries. Assessment of the side branches, making sure that there's no dissection in the brachiocephalix. Detection of a pericardial or pleural effusion, as well as detection of tamponade. So CTA will only give you a limited amount, where the echo is really going to give you the assessment of all these other things that are important in the management of this patient. So the initial echo findings by one of my colleagues that this was a type A dissection extending from the right and non-coronary cusps. It had interfered with the coaptation, resulting in a central AI jet. This patient extended all the way down into the descending aorta, below the diaphragm. Normal LV and RV function on exam prior to surgery. Significant left ventricular hypertrophy, which fits with the uncontrolled hypertension that this patient had. There was a PFO that was present, and then a trivial pericardial effusion. So how are you going to identify the true versus the false lumen? Well, the true lumen is typically smaller than the false lumen. And it has a systolic expansion where false has diastolic expansion. Flow is antegrade in the true lumen. False lumen has slow flow and oftentimes has thrombus formation. Aortic arch is on the inner contour of the true lumen, and flow in the true is from the true lumen to the false lumen. Laminar in true and slow reversed in false. So you can see here, you can see the flow in the true lumen, which is typically in the smaller. Really no flow or low flow in the false lumen, which is the larger area of that aorta there. Again, you can see the expansion of the true lumen on the 3D echo here. And you're really going to look at these TE views that we talked about in the aortic lecture. So you can see there going from one in the ascending aorta all the way to the arch and then the descending aorta, but multiple different areas of the descending aorta to really ensure that this doesn't extend all the way down past the diaphragm. So and then you're also looking at your aortic valve. So those are the typical views you want, but then again, you're still going to assess other functions. So you're still going to do function of the left ventricle, seeing if there's any issues with that. You're going to try to assess the coronaries. You're going to look for pericardial effusions, pleural effusions as well. So these aren't the only images you want. These are just typical aortic images that you want to evaluate to ensure you're really evaluating this dissection, but then there's other images that you need to make sure that you're evaluating to have a clear picture of what's going on in this patient. We saw some good images before where the intimal flap really went in between the cusp of the aortic valve. We can see here this patient that came into our OR had a decent sized flap, and you could see it in the short axis view. And this is a separate patient, just because this patient came through 2 weeks ago. A very similar flap in this patient. You can see the dilation of the sinotubular junction and the aortic regurgitation that we have here as well. and then the resultant left ventricular dysfunction in this second patient. So not in the case presentation, but this patient did have some changes as well. So put this patient to sleep, went to surgery, went on surgeon dissected, and it found that it involved the ascending aorta, but did not involve the region of the root. So the surgeon decided to put a root-sparing ascending aortic graft in place, did not replace the aortic valve, but upon weaning from bypass, this patient had a mild to moderate decline in RV function and a severe decline in LV function. And we found that severe anteroseptal hypokinesis of the left ventricle. They gave protamine and found severe right atrial enlargement, severe right ventricular dysfunction, and worsening LV function after that. So what types of things are you thinking can complications from an aortic dissection? Well, aortic insufficiency. So 40 to 76% of all cases are going to have some sort of AI. Occlusion of the coronary artery, 10 to 15% of cases. Rupture, tamponade, ischemia of the viscera, and cerebrovascular accident. We talked about this a little bit earlier. Aortic insufficiency, so there's kind of three different types that we're going to have here. We have type A there, where there's incomplete closure when the STJ dilates. And you can see this is because the annulus is open and you can't have closure of the valves, and you're going to have aortic regurgitation there. Type B there, in the second one there, you can see that the flap is preventing the opening or fully closing of one of the valves or one of the cusps. And then the following one is when it kind of projects into between the cusp of the aortic valve and has an impact there. So there's three different types that typically will cause, and we saw different types there in our previous one. You can see here again where this one is dilating that STJ. You're going to have the aortic regurgitation. And then this patient ended up just getting an aortic valve replacement. They tacked down the dissection. They didn't replace it at all. They didn't feel like this patient would do well by going on, by removing the aorta, so they just kind of tacked it down, and 2 weeks out, this patient's doing well. Back to the first patient. Once they saw those changes with the RV and the LV, they initiated VA ECMO. They did an intraoperative coronary cath and found dissection of both the LAD and the right coronary arteries. They underwent a 3-vessel CABG, and the patient was brought to the ICU on VA ECMO. And unfortunately, about a week and a half after the initial surgery, this patient died. We talked about this previously, but this is also helpful in any stentings procedures as well, so you can use TE for that. In pre-stent deployment, this is going to be helpful to measure the diameter of the aorta and confirm the stent size, identify the true and false lumen and correct position of the catheter, again making sure that the catheter isn't placed into the false lumen. And then after stent deployment, we want to check for stent leaks and then correct apposition of the stent. But TE isn't perfect. There are limitations. There's reverberations that can interfere as the intimal flap, so you really want to make sure that this truly is, and a lot of times just color flow Doppler will show what it is. Availability, as I talked about earlier, this would be great if you could do it in the emergency room, but it's not very common that we can do it at our institution or many institutions. Need for sedation for patients. Distal ascending aorta, proximal arch may not be adequately visualized due to the trachea and left main bronchus. There is the modified A-view where there's the special left main bronchus catheter that you can put in with, fill it with saline and see the aortic arch, but tends to be a little bit cumbersome to do in the real world. Inconsistent views of the abdominal branch vessels, and then sometimes the left innominate may appear as a tear. You can see that here, where you can see the left innominate there in the short axis of the arch. Many times people will call that as a tear, but it's just a left innominate there, creating the appearance of that, so making sure that that truly is a tear before you call it in the operating room. And then reverberation, again, as we talked about, you saw in previous, it seems like there may be a flap there, but as you put color flow Doppler on there, you see flow through there, and that it's definitely not. And that's it.